So X-ray is a reliable tool after 4 or 6 months of age, used for diagnosis, monitoring, and follow-up, and it is a surrogate, absolute measure, to indicate after 2 years of age. If you find X-ray of the 7-month baby, you cannot find the femoral head, but with the certain parameters like the vertical line and horizontal line, you can indicate which hip is inside, which hip is out. Like this X-ray, you can find, normally you cannot see, but if you follow a Shenton line here and the distance from triradiate cartilage to the hair, you will find this hip is okay, like this. While on this hip, there is no femoral head, so you cannot say. So the metaphysis of this femur, this metaphysis, is seen not in this inside lower triangle, but outside and upper triangle. So this hip seems to be a dislocated hip. So again, this same parameters on my same patient and another patient here, you'll find a normal hip, a Hilgenreiner, and the vertical line you form, and then the acetabular index as well, which must be at the birth age 30 degrees and gradually decrease up to the 22 degrees. The Hilgenreiner line is horizontal line, Perkin line is vertical line. So in this case, particularly in both these cases where you can find the femoral physis, you cannot find the femoral epiphysis. If compare this with this figure, so there is again the same the line outer touching other, but not here. It must be here. So there is a broken Shenton line here, normal Shenton line here. This physis inside lower quadrant, this side metaphysis is there, but the physis is the outside, not here. So this is a subluxated or dislocated, frank dislocated hip. We further evaluate with another parameter, acetabular index. Sometimes find nearly towards the acetabulum. So Shenton line is broken. It is lateral to the Perkin line, above the horizontal. So it produces another type. Then if you are in suspicion, or in case when you apply the plaster, you can do the Rosen View. So Rosen View is done particularly 45 degree of the abduction of the hip joint, like this, and internal rotation of 25 degrees. When you do internal rotation, then the femoral head becomes prominent. So when you draw an axis along the femur, that this line normally should cross through the acetabulum at any point through the acetabulum. Best is through the triradiate cartilage. It should cross through the triradiate cut, but even if it is crossing the acetabulum any portion or the same side of the SI joint, then it is called normal. But if it is this line is out of the acetabulum edge and crossing towards the other sacroiliac joint, then it is called subluxated or dislocated hip. This is again another example. It's normal side. On this side, it is touching to the ear, but if you do the internal rotation, it will really touch from this triradiate cartilage and go through the same SI joint. But if it is dislocated, it not go to the same SI joint, but it is out of the acetabular edge and it crosses opposite SI joint. So this is for 45 degree abduction on both and internal rotation, that is called Rosen View. So this is one of my patients who came with me post-op X-ray follow-up for some referred from somewhere else. I feel that you must have a second opinion. So I draw this line and found this acetabulum is crossing through the triradiate cartilage, but here triradiate cartilage here, it is just above the edge. So in this condition, there is a suspicion that there is no reduction of the acetabulum here. Therefore, we use further tools, which is called, this is the basically Tönnis grading, and there is a universal grading as well. In this recent cases, there are 3 types normal. There is a vertical line here, and then a line from the edge of the acetabulum here, Tönnis grading ke liye, and then you find inside normal. But if it is outer, if it is below this line and below lateral to this is called type 2 dislocation, 2 height of dislocation of the acetabulum, like in this case. So here is the type 2 dislocation bilaterally. Type 2 because acetabulum angle is around 40 degrees. And if you find another case, she presented 19 months of the age. She was nowadays grown up 10 years old child. I will present this case in the next meeting, next class. So if you do the Tönnis grading in this particular case, it is type 3. It is above this line, type 3 Tönnis grading. But frank dislocation of the 10 years age, it's also girl become very good after reduction. So here you find frank dislocations, type 4 Tönnis grading. So when another parameter of the judging on X-ray is the central edge angle, particularly in post-reduction in adults. We see how much coverage of the femoral head is, how much femoral head is uncovered. So if you compare these two figures, this will indicate you uncoverage of femoral head. So it is the center point where the physis and epiphysis joinite. Center, take a vertical line up and another line from the angle acetabulum here. This indicates of the CE angle. In 6 up to the 13 years, it is greater than 19 degree. If this angle increases like this, it means the coverage is more on this side. If this angle reduces, it means bony coverage is less as compared to the here. So after 13 years, this must be 25 to 45 degrees. 35 to 45 degrees acceptable. But if the angle reduces, this means the head is either uncoverage. If the angle is goes to the negative side, it means he is doing a protuser acetabulum. If we compare this, there is this edge center angle here, and it is along the region 15 or 20 degrees, 15 degrees here. So this is more, head is uncovered. There is a subluxated head, obtuse acetabulum, and uncovered femoral head. There is more details of another subtypes of this available, which we don't need to discuss here. Then angle of anteversion, how to check on the X-ray. Do the abduction, place the patient on the table and abduct and internal rotate. Abduct and internal, you will find a normal angle with this top of the acetabulum and angle of the axis of the femur. This axis of the femur with the top of the table, it produces an angle which is called acetabular index. But in this case, it increased more than 50 degrees because there is increased anteversion. Then there is this is called frog leg views, abduction and the external rotation. Then nowadays we use the CT, superposed CP. This was the same case which you have seen on the X-ray, like this case. So I was suspicious whether it is inside or outside. So we done the CT scan because of the plaster cast was there, and that indicate again a dislocated hip. But this tool is also used, CT scan, by superposing the femoral condyle with the axis of the femur. So this is the femoral condyle axis. This is the femoral condyle axis and the axis of the femur. You do in same straight view X-ray of the hip joint and X-ray of the knee joint. And then these composition, computer composition will tell you how much this femur is rotated externally and with the axis of the femur. So this figure comes as the femoral anteversion. And then MRI is very less used, particularly if you find a suspicion of the AVN. So here is other imaging tool which we recently used also in a close reduction case in 3 weeks back in Ziauddin. This is called arthrography. So I was taught by Professor Nizamuddin Jamili in the X-ray department in the ward of Fort UT in 1986. Around 86, how to arthrography should be done. It goes through the anterior iliac femoral artery, lateral to the femoral artery, introduce a cannula, and that is called, I use the LP needle, introduce, this is the K-wire, but not the arthrogram, but this is the arthrogram, just to introduce. I will show you next, I think. And then you will find a normal arthrogram, fully covered with the dye. This is the femoral head, this is the physis. But if it dislocated, this is elongated sheath along the teres ligament, and this is the femoral head, this is the capsule, and here is the labrum, which is inverted labrum, and here is the pulvinar. This black shadow is pulvinar, white shadow is the dye which we use. And again, same here, the labrum, ligamentum teres, and C-shaped coverage over the femoral head and dislocated hip. So this was again a same case in which CT scan we used, and after follow-up we found a there is dislocation here, dislocation in the initially at the after removal of the cast, and this went good. So because of this screening protocols, the wide of screening protocol becoming misdislocation is becoming in the Europe. It is only 5 to 6%, and nowadays after 2002 indication there is no misdislocation because they very carefully do the ultrasonography and the bracing in these conditions. Unfortunately, unsuccessfully treated dislocation of hip is more common in the Turkey and the Iran and more in the Pakistan, though they have good protocols. Now, Bangladesh also started the good protocol for the screening, but in our country, it has been not. So dislocation, miscirculation cases are more than 25%, were indicated with Zade, very popular paper of the Catrol and Zade 2000. But our statistics in 1997, first article when I published, I said half of the children above 3 years of age, they present to us. So please follow the link for screening protocol to see how to do. This is my YouTube. You can find this link as well, and screening protocols you will find.